Good morning. I'm Miguel Perales. I'm Deputy Chief of the Transplant Service at Memorial Sloan Kettering in New York. And today I'm going to talk about the use of checkpoint inhibitors in the setting of a bone marrow transplant. So I think what's very interesting recently, there's been a lot of data of checkpoint inhibitors in patients before or after transplant. And particularly in the setting of lymphoma, what we've seen is very exciting data in Hodgkin's lymphoma. In the patients with non-Hodgkin's lymphoma, we're still trying to define where these drugs can fit in because the activity is not as strong. But in Hodgkin's lymphoma, due to the unique genetics of this disease, we've seen remarkable results. And we now have results from both nivolumab and pembrolizumab in patients who failed an autologous transplant, patients who've been exposed to brentuximab or haven't been exposed to brentuximab. And across the board, the results are really excellent. So one of the most interesting studies that was recently published is a combination of brentuximab and nivolumab in patients with refractory lymphoma. And so this is almost the holy grail in Hodgkin's lymphoma. It's sort of the chemotherapy-free approach to treating these patients. And so those results, although they're preliminary, were quite exciting. And I think many of us are thinking of where we go next in terms of potentially treating patients earlier with this type of drug. There was also a presentation at ASH in 2017, which was interesting, is looking at the treatment of patients upfront with checkpoint inhibitors, particularly nivolumab. And those results in combination with chemotherapy were quite promising. And the German group is actually moving forward with a study upfront now, randomized trial, where they're going to be comparing the use of nivolumab upfront with or without chemotherapy, and that study is going to be ongoing. So I think very soon we'll see new developments in this field in terms of the checkpoint inhibitors moving early in the treatment of Hodgkin's lymphoma patients. Now another question which I think is also very relevant to these drugs, we know that these drugs basically take the brakes off the immune system, and so one of the questions is how do you safely use these drugs in the context of an allogeneic transplant? And we know that one of the main complications there is graft versus host disease. So we do have some data in that regard. There was a study published last year, which was really a multi-center retrospective study where we looked at about 39 patients who had been exposed to checkpoint inhibitors and then underwent an allogeneic transplant. And what we can tell from those results is that you can safely do a transplant. The risk of GVHD is not increased. There is some more severe GVHD. And what we also saw is that there were also immune adverse events such that the patients who were exposed to steroids was higher. So I think we do have to be a bit careful about how we manage these patients. And one approach we've taken at our center is actually to use post-transplant cyclophosphamide to try and reduce the risk of graft versus host disease. And finally, there's two recent papers looking at the use of these drugs after transplant for patients who relapse. And there the results are still a bit conflicting. There was a French study specifically in Hodgkin's lymphoma that showed very good responses and a relatively good safety profile. But there was also a US study which did indicate a high risk of graft versus host disease, including fatal graft versus host disease. So I think we still have to be a little bit careful about how we use checkpoint inhibitors after a donor transplant because of the risk of complications.